Okay, welcome to this tutorial. So today we'll be looking at understanding renal disorders, a focus on acute kidney injury, move from the normal physiology to the disease condition. So let's get right into the objectives of this tutorial. So the objective will be to understand the primary anatomy and physiology of the kidney, the blood vessels around the kidney, and the roles and functions of the kidney, as well as the definition, types, and causes of the acute kidney injury, otherwise called AKI. Then clinical presentations and urinalysis interpretation. Then you apply the knowledge through clinical case study. So if you are ready, let's delve into the basic anatomy and physiology of the kidney. So here is the gross anatomy of the kidney. It's located retroperitoneally behind the peritoneum and the peritoneal space. It's about 10 to 12 centimeter long and weighs about 150 grams. So some of the structures quite written, the outer cortex contains the glomeruli and the convoluted tubule, and the inner medulla contains the loop of Henle and collecting ducts. So yeah, quickly, here is a very quick structure or diagram to illustrate the whole anatomy. So you can see the renal cortex over here. So you can see the renal cortex over there. Yeah, so you can see the renal cortex, the renal pyramids. Of note is your renal pyramids. The renal pyramids. That is where the nephrons are located. So quickly, microscopic anatomy of the nephron. So the kidney is an organ. So the functional unit of the kidney is the nephron. The kidney contains about 1 million nephrons, approximately 1 million nephrons. And the components of the nephrons, they are the renal corpuscle comprise the glomerulus and the Bowman's capsule, the proximal convoluted tubule, the loop of Henle, descending and ascending, the circumconvoluted tubule, and the collecting ducts. So these are the structures, the components of the nephron. So let's quickly look at the diagram of the nephron. Yeah, so here is an illustration of how the nephron looks like. So you can see the glomerulus. This is the glomerulus here. Yeah, that particular place. Let me show you this particular place. That's the glomerulus inside the Bowman capsules, and here is the proximal tubule. That's the proximal tubule. This is the loop of Henle. This is the collecting duct. So that is how the nephron basically looks like. So we're moving on to the next. Now, what are the key physiological processes of the kidney? It's responsible for filtration about 280 liters of fluid is filtered daily. Then it's responsible for reabsorption of necessary nutrients like your glucose and some certain nutrients that need to be reabsorbed back into the body. Then it secretes other waste products. Then it helps concentrate your urine. Yeah, so understanding the kidney vasculature, like the blood supply of the kidney. So from here you can see here you can see that the primary blood supply to the kidney is from the renal artery over here. Then it innervates the whole kidney, specifically the nephron. then it goes back to the heart through the renal vein as shown here. Yeah, so now looking at it microscopically, because the nephron is the functional unit of the cell, we have this diagram over here. We have the diagram over here. So let's look at it very well. We can see here, we can see the from the renal arteries, you have the afferent arterioles. The afferent arterioles are smaller than the renal artery. It enters into the Bowman's capsule, otherwise called glomerular capsule. Once it enters, it splits into smaller sizes. As you can see here, yeah, the smaller sizes. Split into smaller sizes. You can see here where yeah, so those smaller sizes, they are your glomerulus. So your glomerulus is just in like a network, a net of small blood vessels. So the filtration occurs here. So once filtration is done, the urine flows and enters into the collecting duct where it is being passed out. So basically, the afferent arterioles enter into the Bowman capsule from the glomerulus, comes out as the afferent arterioles. Comes out as the efferent, not afferent, efferent arterioles. So basically, that is what you need to know concerning the vasculature of the kidney. So now we're looking at the clinical significance of this whole vasculature. Number one is autoregulation. There's constant autoregulation of the glomerular filtration rate, irrespective of changes in blood pressure, by some certain substance secreted by the kidney. It regulates the renin-angiotensin system, the RAS. Then the renal blood flow to the kidney, of course, is about 20 to 25% of the flow that comes from the heart, the blood that comes from the heart. So, okay, excuse me, coming, yeah, clinical significance. So now the roles and the functions of the kidney. So what are the roles and the functions of the kidney? Number one, their primary function is to excrete waste products like your urea, creatinine, uric acid, some drugs. Of course, once you take a drug, metabolized and excreted by the kidney. Toxin elimination, to regulate fluid balance, electrolyte balance, acid-base balance, then endocrine function to produce renin for regulation of BP, to produce erythropoietin for RBC production. Of course, once the kidney senses that there is a low red blood cell in the blood, it begins production of red blood cells. Vitamin D activation, that is for calcium metabolism, then prostaglandin synthesis. Take note, the first two functions, that is the excretory and the regulatory function, is what is majorly affected in acute kidney injury. While the last function, the endocrine function, is what is majorly affected during chronic kidney injury. So in chronic kidney injury, you'll be seeing some certain things like increase in parathyroid hormone. You'll be seeing things like pneumochronic pneumocytic anemia. So you'll be seeing something like that. It has to do with the endocrine. So now let's look at how the kidney regulates glomerular filtration rate. So now I told you from this is your blood vessel from the vasculature of the kidney. So you have your afferent arterioles coming from the afferent, the artery. Yeah, the artery, it divides to form the afferent arteriole. Then it enters into the Bowman's capsule, as written here. into the Bowman's capsule, where it divides into smaller blood vessels. Those smaller blood vessels you can see here, you can see them here. They are what we call the glomerulus. The glomerulus. That's your glomerulus. That's your glomerulus. So once it splits, it goes out of the glomerulus to innervate the whole kidney tubule via your efferent arterioles. So the pressure here must be as much as possible, or as optimum as possible, to ensure optimum glomerular filtration rate. And one way the body does that is by vasodilating these particular afferent arterioles. So once there is a vasodilation here and there is a vasoconstriction at the efferent arterioles, there is buildup of pressure, because the amount of blood entering through this direction, see the amount of blood flowing out, but the efferent arteriole is smaller now compared to the afferent arteriole. So there will build up of pressure here that will cause filtration. So, but if the reverse is the case, that is, you vasoconstrict the efferent as written here, it decreases the GFR. If you vasoconstrict the efferent, as I have explained earlier, it increases the GFR. And two major molecule, or two major substances the kidney produce that regulates this is, first of all, your prostaglandin. Prostaglandin acts on this afferent arteriole to cause vasodilation. The kidney also produces angiotensin 2, which acts on this efferent arteriole to cause vasoconstriction. So these two things will increase or make sure that the glomerular filtration rate is maintained. So if somebody has acute kidney injury where there is a compromise in the GFR, it is important that these drugs, any drug that inhibits prostaglandin synthesis or antagonizes angiotensin 2, should be stopped for the meantime. Okay, moving to the next slide. So now, definition, types and causes of AKI. So what is AKI? AKI is a rapid decline in kidney function over hours to days, characterized by a sudden increase in serum creatinine and a reduction in urine output. So the serum creatinine is used to measure the function of the kidney. Once there is a rapid and sudden decline in this kidney function, characterized by an increase in serum creatinine or a reduction in urine output, the person is suspected to have acute kidney injury. So what are the types and causes? So the first type, the types of acute kidney injury is actually classified based on the location of the injury. The location of the injury, whether it is before the renal system or inside the renal system. So when we say inside the renal system, now we are talking about everything that has to do with the nephron, anything that has to do with the nephron, or after the nephron, that is postrenal, after the nephron, after the kidney. So first of all, we have your prerenal AKI, also known as functional AKI. It is responsible for 55 to 60% of the common acute kidney injury, and it is caused due to decreased renal perfusion. That is why it's called functional. So when there is a reduced blood supply to the kidney, and what can cause a reduced blood supply? When there is volume depletion via dehydration, hemorrhage, diarrhea, heart failure, congestive heart failure, the heart cannot pump enough blood to the kidney. When there is shock, if you are using medication. Now I mentioned earlier when I was explaining the regulation of glomerular filtration rate, exactly here. So I mentioned earlier how this can affect your sorry oh sorry yeah sorry sorry about that. Now, prerenal AKI is caused by the following medications: ACE inhibitors like lisinopril, um, and so on. Then renal artery stenosis, that is when there is a constriction or a constriction of the renal artery. So anything that happens here affects the kidney. Anything that happens at the renal artery or the renal vein affects the kidney function, reduces the blood supply to the kidney, and results into acute kidney injury. So the urine is clean, the urine is pure, but there is an injury already. Now, the second one is your intrinsic. Okay, now intrinsic in your intrarenal AKI, it affects the kidney, the nephron itself. So anything that affects the nephron and tend to alter the function of the kidney is classified under intrarenal acute kidney injury. So what's the mechanism? Direct kidney damage, that is this the only thing that happens here directly affects the nephron. So it's not functional, it's something that has to do with the nephron, things affecting the nephron. What are the causes? Number one is we have acute tubular necrosis. So this is one of the causes of intrarenal AKI, acute tubular necrosis. So these are the tubules, these things here, these are the tubules, these are the tubules, these are the tubule. So, and they are actively reabsorbing and secreting certain substances. So it's important that there is adequate blood supply to them. So it's important that there is accurate or optimum blood supply. Now, when there is a reduced blood supply, probably the use of drugs or ischemia, reduced blood supply to the tubule, it causes acute tubular necrosis. So first cause of acute tubular necrosis, as shown here, is ischemia. That means your prerenal AKI can actually result into intrarenal AKI, especially acute tubular necrosis. So another thing that can cause acute tubular necrosis is nephrotoxins. So from the word nephrotoxins, that is the nephron and things that are toxic to the nephron. Example of things that are toxic to the nephron, they are endogenous. Some are produced by body. Example is myoglobin, and hemoglobin. So myoglobin is a product from the breakdown of the muscle, otherwise called rhabdomyolysis. Rhabdomyolysis. So that's it. Rhabdomyolysis. Now, other exogenous nephrotoxic substances that can cause acute tubular necrosis is amphotericin B, aminoglycoside, chemotherapeutic drugs used for cancer, some diuretics, and as well as some anti-epileptic agent like phenytoin. So now, once you take those drugs, or once those drugs enters into the kidney, they cause injury, they cause insult, they cause pain, they cause injury to this part of the kidney, the tubules, leading to their death. And because the word necrosis means death. Now, the other form of intrarenal AKI is your glomerulonephritis. This has to do with the glomerulus. Remember where the glomerulus is, right? Here, it has to do with the glomerulus. So anything that causes inflammation of the glomerulus would definitely cause acute kidney injury. Now, the most common form of glomerulonephritis is your post-streptococcal glomerulonephritis. This occurs after a streptococcal infection. So, in an infection, your body tries to fight the invading microorganism by creating antibody that bind to the antigen presented by the organism. So this antigen antibody complex can get deposited in the glomerulus. The glomerulus is responsible for filtering everything that's in the blood, so it can filter this immune complex. And once it gets deposited on the glomerulus, it triggers a serious inflammatory reaction that compromises the integrity of the glomerulus. So the glomerulus become porous, leading to filtration of things that should not even be filtered. Example is your red blood cells. Example is proteins. So you begin to see the red blood cells in the urine, protein in the urine. You see red blood cell cast in the urine, and proteinuria, protein in the urine. So these symptoms, proteinuria, lab test, lab investigation, see protein in the urine, you see red blood cell cast in the urine, they are classical indication that the AKI is intrarenal and it is glomerulonephritis. For acute tubular necrosis, you tend to see brown cast because as the cell of the tubules are dying, they begin to slough off into the urine, forming brown cast, a dead brown cell. So the next, we've talked about acute tubular necrosis, talk about glomerulonephritis. Let's go into interstitial nephritis right now. So interstitial nephritis, this is the interstitium, the spaces between the tubules and the blood vessels that innervate the tubule, like these small spaces here. It's what we call the interstitium. Yeah. So they can get inflamed, interstitial nephritis, by the use of some drugs and some certain infections that can lead to acute kidney injury. So drugs like antibiotics like penicillins and cephalosporins can cause hypersensitivity reaction leading to the inflammation of the interstitium. So infections like systemic lupus erythematosus, that is SLE, can also cause interstitial nephritis. Then the other cause of intrarenal AKI is vasculitis, that is inflammation of the blood vessel, or malignant hypertension. So let's quickly go to the postrenal AKI. So this is just to explain glomerulonephritis better. So postrenal AKI has to do with anything beyond the nephron. So we know this is the kidney, this is where the nephron is, this is the kidney. So this is the kidney. This is the kidney. This is the kidney, and that is where the nephron is located. Anything outside the kidney here is called postrenal. It's called postrenal. Anything outside the kidney is called postrenal. So the mechanism is that there is urinary tract obstruction, and this can be caused by bladder outlet obstruction, the benign prostatic hyperplasia. That is, if this prostate here becomes inflamed, it constricts the urethra, leading to reduced urine output. Then stones too, urethral obstruction, that is, if there is any obstruction here, let me show you. If there's any obstruction here, whether it is kidney stone or whatsoever, it causes reduced urine outflow. it reduces the urine that gets into the bladder. So these are the three major types of acute kidney injury. So to review it, we have the prerenal, that is the one that happens before the kidney, and it's basically volume depletion. Anything that depletes the amount of blood getting to the kidney. We have the intrarenal, the things that affect the nephron, which can be um, which could be acute tubular necrosis caused by ischemia, reduced blood supply, nephrotoxin, which is either endogenous or exogenous. Classically, the signs you see in acute tubular necrosis is muddy casts or brown cast urine, a brown cast in the urine, muddy urine or brown cast in the urine. So the other one, you have glomerulonephritis. Most common example is your post-streptococcal glomerulonephritis caused by an infection caused by streptococcus. The last one is your interstitial nephritis and a hypersensitive reaction. The classical signs or manifestation of interstitial nephritis is rash, fever, and eosinophilia. That is, there is increased eosinophils in the blood, which can be excreted in the urine, so called eosinophiluria. So anytime you see the eosinophils in the blood or in the urine, it is directly indicative of interstitial nephritis. So you have your postrenal too. Now let's look at the urinary indices in AKI. So what are the urinary indices once you take your urinalysis? Now, in prerenal, the osmolality is greater than 500, while in others it is less than 400. So osmolality is the concentration of the urine, that is the concentration of the urine. Why is it high in prerenal? Is that in prerenal there is volume depletion. Remember, blood volume reduces. There is reduction in blood volume, so the body tends to reabsorb the whole water, any available water in the kidney, leading to increased osmolality. Now, while in the other cases there is no depletion in volume, it's just injury to the kidney. So for prerenal, the sodium content of the body of the kidney is quite low. It's quite low. It's less than 20. Why? Because the body is reabsorbing the whole sodium being filtered, so that water can follow and blood volume can be restored. For the others, it's quite high, and this is as a result of the fact that the tubules are not even functional, and they cannot reabsorb properly. So in the fractional extraction of sodium, we can see that in prerenal the body extracts sodium very well. It's less than 1. Fractional extraction is based on is the relationship between the filtered sodium and the absorbed sodium. For prerenal, it's less than 1. Absolutely, it is highly absorbed, while the others is greater than 2. So for protein in the urine, in intrarenal, especially glomerulonephritis, you can see that is about 3.5, and I have explained that because the integrity of glomerulus become compromised, you can see protein in the urine. For the tubules, of course, death of cells will lead to some certain types of protein that are expressed on the surface of cells to be present in the urine. An example of that type of protein is your beta 2 microglobulin, while that one present in glomerulonephritis is albumin. So for the cast cells, for the cast cells, you have white and red blood cell cast for glomerular nephritis. You know why you're seeing those casts? Because the integrity of the glomerulus has been compromised due to inflammation. For eosinophils, you see eosinophils. For the eosinophils, it's only present in interstitial nephritis. It's only present in interstitial nephritis. Then the blood urea nitrogen to the ratio of blood urea nitrogen to serum creatinine is quite high for prerenal because the body is absorbing all source of solutes, including urea, so that it can bulk up or increase blood volume. So, but it's quite low for the other types of AKI. So now we'll be going to the last slide, which is a clinical case study. A 25-year-old female presented to her primary health care physician complaining of swollen hands for the last week. She had also noticed that over the last 2 days she was getting swelling around her eyes. This swelling around her eyes and was short of breath. History revealed that 3 weeks ago she had infected skin lesions on her thighs that had been treated with an antibiotic ointment from her doctor. Urinalysis result shows oliguria, which is reduced urine output, blood and protein in the urine. Blood, that's red blood cells or blood in general, then protein in the urine, proteinuria. Red blood cells and white blood cell cast could also be seen on microscopy. What is the most likely cause of AKI in this female patient? So things that you should take note of. Remember, she has swollen hands, swelling around her eyes. She had an infected skin lesions on her thighs, which is caused by streptococcus. In analyzing the urine, she has oliguria, reduced urine output, indicative of an injury already. You are seeing blood and protein in the urine. Of course, this is not going to be prerenal because there is no reduced blood volume, and the urinalysis result is showing that there is something wrong with the nephron already. So you are seeing blood and protein in the urine. You are seeing red blood cells and white blood cell cast. So you are not seeing muddy urine. So this is not acute tubular necrosis. You are not seeing eosinophils or rash or fever. This is not interstitial nephritis. This is classical glomerular nephritis caused by an infection, streptococcal infection. So the reason why you are seeing swollen hands, swollen eyes, it looks like she has edema. She has edema. So as protein is being excreted, protein is present in the blood and is responsible for the oncotic pressure of the blood. So as protein is being excreted, you see protein in the urine, right? Yeah, protein in the urine. So the oncotic pressure of the blood reduces. The oncotic pressure of the blood reduces. So once the oncotic pressure of the blood reduces, fluid leaves the blood into the extracellular space, resulting into the swollen face, swollen hands, and swollen eyes. So the most likely cause of this AKI, number one, is an AKI. Number two, it is intrarenal, and the example of the intrarenal AKI is glomerular nephritis, and the cause is post-streptococcal glomerular nephritis. So I hope you've learned a thing or two from this tutorial. If you have any question, you can email me. My email is on this first slide. Thank you very much. We'll see you again.